Hi, and welcome to the July 2026 DermSurgery Digest podcast. I am the podcast editor, Naomi Lawrence, Cooper Hospital, Rowan University. In this month's Rapid Pearl segment, focused on cosmetic and general dermatologic procedures, we have Ardalan Minokadeh from Skin Care and Laser in Los Angeles doing the article summaries, and Kristel Polder from Dallas Center for Dermatology and Aesthetics, providing clinical application and tips. Please don't forget that we continue to offer Beyond the Digest, a podcast covering articles focused on dermatologic surgery but outside of the Dermatologic Surgery Journal, and At the Microscope, a quarterly publication that is topic-focused on histopathologic content relevant to dermatologic surgery. Thank you for listening and have a happy surgery day.
Welcome to this month's DermSurgery Digest, where we'll review the cosmetic leaning manuscripts from the journal Dermatologic Surgery. I'm Ardalan Minokadeh, ASDS member and dermatologist practicing at Skin Care and Laser Physicians of Beverly Hills in Los Angeles, California. Today I'm serving as the junior editor along with our esteemed guest contributor, Dr. Kristel Polder. I'm truly honored to introduce Dr. Kristel Polder, a partner at the Dallas Center for Dermatology and Aesthetics and clinical professor at UT Southwestern. She is widely recognized as an expert in cosmetic lasers, injectables, and skin rejuvenation. She's co-author of the book Beautiful Skin Revealed and a highly sought-after speaker who has lectured at numerous national and international meetings. Beyond her private practice, she's deeply committed to mentoring the next generation of physicians through extensive leadership roles within the ASDS. And most notably, she's served as expert faculty for over a decade at the prestigious ASDS Premier Annual Resident Cosmetic Symposium, where she leads hands-on injection training and lectures to top dermatology residents from across the country. Welcome, Dr. Polder.
Thank you so much, Ardalan, for that amazing intro. I'm honored to be here.
Of course, thank you again. The next section is going to be rapid fire, Dr. Polder. So I'll briefly discuss or briefly mention the manuscript, and then I'll ask you for kind of a key pearl or key takeaway that you can share with our audience. The first manuscript in this section is Injectable Therapy for Androgenetic Alopecia, a Systematic Review. So this is a systematic review looking at different databases, and ultimately 30 studies were identified. And they looked and showed in Table 1 and Figure 1 the variety of techniques that are used for androgenetic alopecia. They state that randomized trials should be performed before any injectable therapy can be recommended. But what's your thought on this systematic review, Dr. Polder?
Well, in the review, they list dutasteride as being the one that has the most evidence to support it. And there are several reasons why dutasteride would be more efficacious than minoxidil, some of the growth factors and peptide injections that they allude to and mentioned that they looked at. Number one, really long half-life on dutasteride. And also the profound suppression of DHT, much greater so than minoxidil, for example. So it's the most studied injectable with no reported sexual side effects. And I think that appeals to a lot of patients. I personally have not tried injectable dutasteride in my clinic, but if I was to try one, that would be the one that I would feel most comfortable after reading this article. I think the questions that I would have are, so we do PRFM in my clinic. So it's that next generation PRP, it's platelet-rich fibrin matrix. What if you combined it with that? What would that look like? Could you get an enhanced result? And then the parameters on that, should you do it same day? Should you heal from one procedure and then do it again? I think this field is also growing. It's very exciting. I think hair loss is a topic that's frequently added on to every skin check that I do. Oh, by the way,
You're right.
what can you do for me for hair loss? So at any rate, I don't know if you currently do injectable dutasteride in your office, but I do think it's very interesting. It's something I would absolutely consider.
That's great. I agree. I don't do it, but if I was to incorporate something, I agree. That's what I'd bring on. That's great points. Thank you. The next manuscript is Platelet-Rich Plasma Accelerates Donor Area Healing After Follicular Unit Excision, a Prospective Study. So this manuscript looked to see if PRP injections help speed up donor area healing after the FUE harvesting for a hair transplant. And they looked at 19 healthy men who underwent FUE transplant, and focal areas were identified, one as a control, one that was treated with PRP post-treatment. And you could see that in figure 3 and 4, there was an image analysis that showed that PRP significantly accelerates donor area wound healing, or what they termed as wound reduction, after the harvesting. What are your thoughts on this, Dr. Polder? And I'm curious, you mentioned that you do PRFM. What are your thoughts here?
So it didn't surprise me. I wished they would have followed these patients out longer. It was only 24 hours that they
Right.
looked at the wound closure, and it was very marked improvement. And I'm not surprised by that. We know that post standard PRP, you have a huge growth factor spike that lasts about 24 hours. You're talking transforming growth factor beta, VEGF, basic fibroblastic growth factor, all the growth factor spike that would improve healing of those wounds. I'd love to see the clinical outcome. Did it result in a reduced appearance of scar at the donor site? That would be very interesting to look at. The reason that we like PRFM, so the fibrin matrix actually causes a more sustained growth factor spike, and that can last up to a week. So I wonder if they were to inject PRFM, what that would look like too. I wish they had done more follow-up, and that I think is the main critique of that article.
Perfect. Thank you so much. The next manuscript is Temporal Artery Mapping with Microvascular Imaging, Anatomical Considerations for Filler Injections. And the authors start with the premise that temple hollowing can be addressed with dermal fillers and that we should all be aware of vascular structures in this area. And they show that they use, quote, microvascular imaging, and they looked at placement of the superficial temporal artery and deep temporal artery in the patients, measured arterial depth in relation to age, gender, and BMI. Ultimately, lower BMI patients or patients with a lower BMI and of younger age had thinner soft tissue, and they note that the deep temporal artery and superficial temporal artery were not consistent. They ran at variable depths. Dr. Polder, we now have two FDA-approved options for filling the temple, and it's gaining a lot of popularity. What were your key takeaways from this paper?
Well, after reading it, and they mentioned it in the conclusion, what I've been doing for the last 17 years is supraperiosteal injections.
Mm,
And based upon what this shows, I believe that to be the safest. And they do talk about the standard sort of one up on the temporal crest, one over from the lateral orbital rim as being the safest point of injection. That's what I teach the residents. That's what we've been doing all this time. They do mention that that deep temporal artery is 0.3 millimeters from the periosteum. That's basically at the periosteum.
right,
It's right
exactly.
there, and it's very small. They did mention that it's not visible by ultrasound in a lot of cases. So, it's hard to hit. Very difficult. I'm going to knock on wood because so far we haven't had any sort of severe event in the temple. I know that one of our colleagues at the ASDS Resident Symposium was using a 22 gauge cannula subdermal and ran into that livido and occlusion, and she had to dissolve it. But
Mm,
that was using a cannula in the subdermal plane, and you think you're safe with the cannula,
right.
but not necessarily, right? This article was interesting because they talked about decreasing BMI as well, and that makes intuitive sense to me too, that your artery epidermis distance is going to be shorter if the person has a shrinking BMI.
Perfect. Thank you for your insights. Thanks. Next is intralesional insulin is superior to intralesional botulinum toxin A in the treatment of keloids. And this is a commentary from the El Radi et al. Paper that looked at intralesional insulin versus botulinum toxin A versus corticosteroids for keloid management. And they had 63 patients, three groups, and they showed that there was a 66% reduction in keloid volume with use of insulin as compared with 25.3 with botulinum toxin A and 75% with corticosteroids. The authors note that insulin appears to be a promising alternative to steroids. I don't personally do this, but I'm curious, Dr. Polder, do you incorporate insulin into your keloid treatment? And how has this paper changed your approach to keloid management?
I don't, but I'm underwhelmed with intralesional Kenalog and 5-FU. I'm going to be honest with you. It's a very frustrating conversation. It's almost like you get the keloid consult and you're like, oh, man.
Hmm.
So I actually printed the article, and we're definitely going to entertain the idea because it's inexpensive, easy to do. And you also wonder, I mean, they didn't study in combination, but what if we combined it? They did mention that there's in the study, patients on oral hypoglycemics were excluded, so your diabetic population. We don't know to what extent it may alter blood glucose levels or even the hemoglobin A1C. So I think all that dose dependent usage of this needs to be looked at. Is there much systemic absorption, and what impact does that have? So we don't know. But I do think this is something that would be easy to incorporate into the practice.
Great, thank you.
As a DermSurgery Digest listener, here is some quick partner information. Mark your calendars out of office this November 5th through 8th. Learn why from our 2026 ASDS Annual Meeting Workgroup Chair.
Hi, I'm Nazanin Sadie, and I wanted to encourage you all to attend the ASDS annual meeting in San Diego this November. It's going to include all of the hottest topics in dermatologic surgery, spanning from cosmetic dermatology to Mohs surgery to reconstruction. We're going to have interesting topics like the latest in GLP-1, wellness, menopause, regenerative medicine, and from experts from around the world. I hope to see you all in San Diego.
To learn more and register today, visit asds.net/annual meeting. The future of dermatologic surgery starts here. And now, let's get back to the conversation.
Next is management of adverse events of botulinum toxin treatment of masseter muscle prominence. And these authors really show their key points in figures 1 and 2, where figure 1 shows a summary of the possible adverse events, management strategies, and preventive strategies for these potential adverse events, namely an undesirable concavity, paradoxical bulging, asymmetric smile, facial laxity, a suboptimal response. And the authors do state that use of ultrasound may further reduce some of these adverse events with respect to visualizing the muscle in a better way. Masseter treatment is not yet FDA approved, but we anticipate it may come out soon, but it's often treated off-label. Dr. Polder, do you have any key takeaways or clinical pearls for our audience today from this manuscript?
So a couple things. I see a huge group of Asian patients in my practice, and I feel like this is very common in China,
Sure.
and all of the Asian countries for that matter, to reduce that masseter volume and change the facial shape a bit. I counsel patients, they do talk about skin laxity. I know you didn't mention that, but they do discuss skin laxity too. And I mentioned that at consultation, that this area was covering a hypertrophied muscle. And if we shrink it, as women, especially, we worry about laxity along our jawline. So we're having that conversation. I will tell you, when we first started injecting it, and I probably started around '09 injecting, masseters, we were doing large quantities. I mean, 40, 60 units per side. Nowadays, no more than 20 in my practice, pretty much on anyone. And I just counsel, conservative. I was always trained. I don't know that we're going to incorporate ultrasound prior to injection. It's such a quick treatment. And knock on wood, I haven't had any issues with any of the complications that they mentioned in this article. But I always grab the belly of the muscle. I feel the contraction and I go right into it. So you feel where they've got that. It's in some cases like a rock. And then I go right in. I did have one patient years ago where just a little band was spasming, and I brought her back, injected it, and it was fine. I think you'd have to be pretty medial to hit the right risorius muscle. And I, knock on wood, have never done that, but I stay lateral. I watch them clench and contract, and I do sort of a little pyramid pattern, two in the belly and then one a little up higher. And knock on wood, have not had issues.
Excellent. Thank you for your insights. Thanks. The next manuscript is back to hair transplants. So follicles twisted during follicular unit excision could survive in the skin of nude mice. And the authors note, starting in the manuscript, that FUE has become a preferred method for hair transplantation. However, doing small and sharp punches to remove the follicles may damage these follicular units and compress or misplace the bulb during the implant, which can affect the success rate of the transplant. They note that in their clinic, they have two types of minor trauma. One, twisted bulbs, or bulbs that rotate axially or roll slightly upward, shown in figure 1A, and shaft fractures, which are separation of either end of the hair follicle into two or more fragments, shown in figure 1B. The question is, it's not known whether survival rates are affected in implanted follicles with this type of minor trauma. So they took follicles from donors of healthy Chinese men with androgenetic alopecia, and 65 of the follicles had the twisted bulbs, 65 had fractured shafts, and then they had controls. These were all transplanted into immunodeficient nude mice, and the survival rates were shown in Table 1. Fractured follicles had the lowest survival rate, twisted follicles were minimally affected, and they state that potentially the twisted follicles may be something that could be used to reduce losses and increase the density of transplants. This is an animal study, and the authors note this and may need to be replicated in humans. But I'm curious, Dr. Polder, does this data give you any insight into the FUE procedure and hair transplantation in general?
I mean, I think the integrity from the shaft inserting into the bulb, that has to be preserved. And so they talked about preserving both the epithelial component as well as the mesenchymal component, and that being critical to the survival of these follicles. If you look at the photos that they had of the fracture, I mean, it looked like a fracture. And I'm not even a hair transplant person. So that would make intuitive sense that if the structure is not sound going in, the survival rate is not going to be great. If you look at the twisting, though, the overall structure was still intact. And so I think this, for the hair transplant surgeons, I'd be interested to hear their thoughts on it too. It makes intuitive sense to me. I'm not surprised by the results.
Perfect. Thank you. The next manuscript, again, hair transplant. A systematic review of follicular unit graft survival rates after hair transplantation in primary cicatricial alopecia. And this is a commentary from a systematic review from Yi et al. Addressing follicular unit graft survival after hair transplantation in primary cicatricial alopecia. And this was a study showing that graft survival peaks at 1 year and declines thereafter, potentially due to subclinical inflammation, donor site involvement, and potentially compromised recipient skin. And the authors of this commentary note that they followed the case of a 36-year-old man who was believed to have, quote, stable disease and underwent a hair transplant that was ultimately unsuccessful. Biopsy from the patient showed that there was perifollicular lymphocytic infiltration consistent with LPP reactivation. So the authors really state that although in what we believe may be a clinically controlled patient in terms of having cicatricial alopecia, there really is no histologic confirmation of this. So they are questioning the idea of looking at clinical parameters to really show whether or not a patient's a great candidate. Do you have any thoughts on this manuscript or this commentary, Dr.
I
Polder?
mean, if I was a hair transplant surgeon, this would definitely give me pause when counseling my patients with lichen planopilaris and also androgenetic alopecia. I think I would sit them down and say, okay, you're about to have a hair transplant, but let me tell you what we know. And the other thing is they were using dermoscopy to look for perifollicular erythema,
Right.
the presence of symptoms, and that this gentleman did not have it, and yet his graft did not survive. So how well does clinical correlate with histological? Apparently not at all. So I would be very cautious. It would definitely give me pause. And this is where you educate the patient, tell them the risk. And if they want to proceed with the hair transplant, then they're aware that it may not take.
Absolutely. Thank you so much. The next manuscript is Pediatric Localized Scleroderma with Favorable Response to 308 nanometer excimer light therapy. So this is a case in this patient of localized scleroderma where the excimer therapy was used. It was a 5-year-old girl with a before and after that was striking in figure 1 and 2 with once weekly treatments. And you can note that there's reduced erythema, and the authors note that there was softening of the sclerotic plaques. So the authors state that there's an advantage of giving targeted delivery of ultraviolet radiation to the affected areas, and especially during the active inflammatory phase. So there's a need for further studies to optimize protocols and identify predictive factors for pediatric patients, the authors state. Do you have any thoughts on this, Dr. Polder?
I think anytime you're counseling the parents of a 5-year-old child about systemic corticosteroids, about CellCept or what other methotrexate. I
Mhm.
mean, I think this would look very appealing to me if I was in a clinic with an eczema laser and if I just said, hey, let's give it 6 weeks or however long the study, which I think was 6 weeks,
Mhm.
weekly treatments before we go all in on some of these other things. And I think as a parent of like my youngest is just a little bit older than the child mentioned in the study, I think I would give it a shot before giving him some heavy hitter drugs that might scare me.
Absolutely. Thank you for that. And now we've actually reached our final of the rapid fire manuscripts, a novel histological method for direct visualization of thermally denatured collagen. And the authors in this manuscript state that there's been a goal in the past to use VVG staining that we're familiar with to visualize thermal damage in dermal collagen, but it's unfortunately not been very consistent and not been very successful, limiting its utility. So they describe a modified version of this called the On Van Giesen stain, or AVG, specifically tailored for the visualization of thermally denatured collagen. And the staining procedure is outlined in Table 1. They took abdominoplasty skin, had a CO2 laser administered to the skin. There are horizontal sections, and in Figure 1, you can see that in Section C, or Figure 1C, there was distinct demarcation of denatured collagen compared to the conventional H&E and VVG, and birefringence images really highlighted the novel aspects of this AVG staining. I know this is a basic science histologic image and study, but Dr. Polder, do you have any key takeaways or clinical pearls you think for our audience related to this manuscript?
Well, it's from Dieter Manstein
Of
from
course.
Germany, which we expect him to have such precision, and he's the pioneer behind fractional photothermolysis with Rox Anderson. And his original histology they showed way back in, I want to say it was around '06 in Lasers and Surgery and Medicine. I remember that slide, you know? So I'm not surprised they came up with a new, more specific, more sharply contrasted staining procedure. And the way they talk about it in the article, these are reagents that you would already have, or it's not going to be very expensive to employ this methodology to really see that zone of denatured collagen, that sharp demarcation. And why is that important? Because they're pioneering probably more energy-based devices. And look, they use deep FX, which is a fractional CO2 in the study. But this may lead to some other things down the line. So I think it's interesting. I think it's very I'm not surprised it's from him.
Well said. Excellent. Well, Dr. Polder, we've reached the end of today's podcast. I want to thank you for your time and for your insight. And I think we all now know why you're so highly sought after for not only lectures, but training our future dermatologists. So I appreciate your efforts on behalf of our audience.
Thank you so much. It was such an honor.
Excellent. Thank you.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.